Hello, and welcome to this episode of In Discussion With from Pharmacy Update Online. Today, I'm talking to Dr. Louise Newson about management of the menopause and perimenopause. Please, could you start by introducing yourself?
I'm Dr. Louise Newson. I'm a physician. I'm a hormone specialist, well, a female hormone specialist. I'm also a medical writer. I'm an author. I'm a podcaster. I'm a researcher, and I'm a mother of three daughters.
And can you give us a brief overview of your current role, what your job involves?
Yeah, I have lots of roles actually, and my most important role is being a medical doctor. So I see patients one day a week. It often spills over to more than that. So I see patients with hormonal problems, so not just menopause and perimenopause, but increasingly I'm seeing a lot of women with PMDD, premenstrual dysphoric disorder, and PMS, premenstrual syndrome, sometimes people with postnatal depression. And then I do a lot of research. I run a small research team. So we're analysing our data, we're doing audits, but we're also writing up papers for peer-reviewed journals, but also abstracts as well. I'm also the founder of Balance app, which is a free app, which it has around 1.5 million downloads. It's a global app, so we're always adding more content to that. And I have my website, which has a lot of articles in, so I add content to that. And then I also run a weekly podcast, which has had over 8.5 million downloads. So I record that, I plan it, I'm always liaising with potential guests, and I often go onto other people's podcasts as well, which obviously I really enjoy. I also do a lot with healthcare professionals education. So we run an education program which we're just updating currently, but I'm also very involved with the content for that. I do a lot of mentoring for our clinicians with Teams chat going all the time, so I'm constantly dipping in and out of that. I'm also very busy on social media, so I'm planning what I'm going to post, what I'm going to talk about, what's going to be put up there. But I have a increasingly huge number of DMs from women, direct messages from women, so I'm keeping abreast of those too. And then I'm also always reading scientific papers and also lots of other books, actually, which all feed into this narrative thinking about health of women and hormones.
Now, what kinds of symptoms do women experience at the menopause? Is it more than hot flushes?
Yeah, it's so interesting, isn't it? Because menopause has almost been defined by hot flushes. And, I'm very interested in the history of medicine. And I think when you understand the history, you can unpick things a lot more. And so when they first discovered hormones, they associated estrogen with hot flushes and night sweats because you could measure it. I can see if sweat's dripping down a lady's face, but if she tells me that she feels low in her mood, she feels anxious, then it's it's easier to not believe her for a start. Not that I would, of course, but it's also you can't measure it with a clipboard. So, and this is just it just carries on really because a lot of research looks at the flushes and sweats and actually they add vaginal dryness because as you might know, they used to assess whether women had enough estrogen in their body by looking at their vagina and seeing if it was looking normal or not, which we know is actually firstly barbaric and secondly it's not accurate. Um, so there's been this wrong information. And when we look at the commonest symptoms of women coming to see us in the clinic, but also we recently analysed hundreds of thousands of symptoms in the Balance app. The commonest symptoms are the ones affecting our brains. So the brain fog, the memory problems, the fatigue, the poor concentration, the poor sleep, the reduced libido, the anxiety, the irritability. I think hot flushes was like number 24. And when we look at the most severe symptoms, again, it's the symptoms affecting our brains. And I'm very interested in neurophysiology, neuropharmacology, neuroanatomy. And it all makes sense because actually the hormones we're talking about, not just estradiol, but progesterone and testosterone, they are made in our brains as well. So this is where some of the misunderstanding has happened, I think, because people just think it's a ovarian condition, it's a period condition, it's just an inconvenience to women. And it's more than that. And it's also just more than symptoms as well, because there are health consequences of having these low hormones too.
Hmm. And what proportion of women experience the symptoms that you describe?
So it's really hard to know, actually, the proportion of people because lots of people, if I stop them in the street and say, do you experience menopausal symptoms? They'll probably say no, because they're really interpreting that as, are you getting any hot flushes? Whereas if I said to them, is your sleep disturbed? Are you getting up at night time to have a wee? Do you have dry, itchy skin? Do you have cystitis? Do you have muscle and joint pain? They'd go, yes, but I don't know whether that's related to their hormones or not. Of course, I don't. So we don't know actually, because there's probably an underreporting of symptoms. But it's also not just menopausal symptoms. We know that perimenopause, so the time before our periods stop, our hormone levels are often quite chaotic. And a lot of people, myself included, have worse symptoms in the perimenopause because our brain likes homeostasis. It likes things the same. So it doesn't really like these fluctuating hormone levels in our brains. So a lot of people have those symptoms because they're responding to the change in hormone levels and the absolute levels, if that makes sense.
Hmm. Let's look at that from a different perspective. What do we know about the impact of these symptoms?
So the impact is huge, and it's very hard to measure because people are misdiagnosed. And I say that with confidence because I have a lot of clinical experience, but I also expose myself a lot to women. And so, for example, a lot of women are diagnosed with mental health conditions, so depression, anxiety being the most common, but even some of the schizoaffective disorders. I've seen people diagnosed and then those symptoms melt away with hormones. So I know it's related to hormones. A lot of people are being diagnosed with seronegative arthropathy, for example, or they might have fibromyalgia, chronic fatigue, long COVID, and no one's thought about their hormones. So we don't actually know like the impact, but we do know that a lot of women have symptoms that are severely affecting the quality of their life. And so we know that, for example, around 10% of women are giving up their jobs and because of their symptoms. And those symptoms that are affecting them most commonly in the workplace are the memory problems, the anxiety, the fatigue. So talking about giving us a hot, something for our hot flushes, a fan or a change of uniform is actually not that helpful in my mind. So we know it has an impact, and we do know most of us do have symptoms. But also, I've mentioned the health consequences. We know that the risk of having a heart attack really increases after menopause, and we know that our chances of dying after a heart attack as women are greater than a man, for example. Less likely to be diagnosed as well if we have symptoms, because often the symptoms aren't classic. Risk of all inflammatory diseases increases. So dementia, osteoporosis, mental health conditions like depression, but cancers can increase, autoimmune diseases, Parkinson's disease, multiple sclerosis, non-alcoholic fatty liver disease. The list goes on because the hormones work in a very biologically active way and they reduce inflammation in the body. So even those women that say, look, I'm managed my menopause, I don't have any symptoms, they'll still have an increased risk. And sometimes this gets misinterpreted that I'm saying that everyone is going to get these diseases. Of course they don't. But we have to understand that in the same way that if I never exercised, I might be fine, but I would know that I'll have an increased risk of heart disease and dementia. That's just fact. And this is where the narrative's sort of changed, and this misinformation that's been fed to women for decades means that they're not part of their treatment choices because they think that treatment is only going to help their hot flushes.
You touched on HRT there, and that's what I want to talk about. Could you just talk to us about HRT and natural menopause?
Yeah, so let's unpick it really because it's three letters which causes a lot of confusion and worry actually, not just for patients but for healthcare practitioners too. So hormone, there's lots of hormones in our body. We know that there's hundreds of hormones. So I think we should be really precise about our language when we talk about hormones. So the three hormones we're talking about in this conversation are progesterone, and I'm saying this really slowly and carefully because there is only one progesterone, which is the progesterone we produce as women when we're younger, and we can prescribe it. It's the same molecular structure, but it's called progesterone. All other progestogens, and again, it's progestogen, not a progesterone. A progestogen means a synthetic progesterone that's been chemically altered. So all other contraceptives, for example, older types of HRT contain a synthetic progestogen. So when I talk about HRT and hormone replacement, I'm really talking about progesterone. And then estradiol, which again is confusing because there's lots of different estrogens. Whereas there's estradiol is the really important anti-inflammatory estrogen that we produce as women, and we can prescribe it through the skin and orally actually. But then we also produce as women estriol and estrone, and estrone is quite an inflammatory type of estrogen. But as you know, in all but one contraceptive, is all the estrogen is ethinyl estradiol, which is quite different. It's a chemical. And in the older days, I mean, I'm old, but I used to prescribe it as well. In the older days, decades ago, it was the conjugated equine estrogens, which were pregnant horses' urine. So you could argue that's natural in your second question about, are things natural or not? Pregnant horses' urine is natural, but I don't want it in my body as a menopausal woman. And so when people think about menopause being natural, it's a huge debate, and it's a bit like, is aging natural? But we have diseases associated with aging, like hypertension, and we quite happily treat them as doctors. But actually, if you think 100 years or so ago, women's average age of menopause was older, it was about 57, and the average age of death was 59. And we spent a lot longer being pregnant. So we had, more hormones in our body. We didn't have, we weren't using our ovaries quite in the same way. So that's probably why we had menopause at an older age. But, we are living longer, which is great, but it means we're living a lot longer without our natural hormones. And we need to be thinking about it when we think about health span of women and trying to keep women healthy and reduce their risk of diseases.
I wonder if I could ask you to talk a bit about the benefits of HRT.
Yeah, so there are two reasons that I prescribe HRT for women. So one is to improve their symptoms, because if their symptoms are due to their low or changing hormones, then giving the right dose will improve their symptoms. As a doctor, I went into medicine to help people feel better. Even if all it does is help them feel better, I don't think that's a bad thing, but obviously it will help with physical symptoms as well. But the other reason that I prescribe hormones is to reduce risk of future diseases. And there's been a lot over the past where it's not in the guidelines about reducing risk of cardiovascular disease or dementia or whatever. But a lot of this is a political thing where you have to look at the evidence. But we do know, for example, that HRT is licensed as a preventative treatment for osteoporosis. Now, 1 in 2, so 50% of women who are menopausal, who don't take hormones, are estimated to develop osteoporosis in their lifetime, and 1 in 3 will have an osteoporotic hip fracture. So, as clinicians, we're encouraged to prescribe treatment if people have a raised cardiovascular risk, for example, of 20–30%. This is a disease that's 50%. And if you have an osteoporotic hip fracture, you might know that mortality in a year is around 20%. It's got a worse prognosis than having a heart attack or most cancers. Yet we're not encouraged to prescribe it for primary prevention, even though it's licensed for it. So we need to just think beyond the box of it for reasons for giving hormones.
Very interesting. And could you say more about the impact on cardiovascular disease?
So I've got a pathology degree as well. So I'm very interested in basic science, and I've got a bit of an annoying mind where I'm very inquisitive and I want to know, but why? Why does it happen? And so when you think about the role, for example, of estradiol in our cardiovascular system, it's really important. It's very anti-inflammatory. It helps with nitric oxide production. It affects prostaglandin, prostacyclin production, and it works as a vasodilator. So therefore, it will help with blood pressure control. It has a really direct effect on our RAS system, our renin-angiotensin system. So it will help control our blood pressure. It also works as an antiarrhythmic, so it will reduce incidence of arrhythmias, including, benign arrhythmias, but also atrial fibrillation as well. And it helps build muscle, so it helps build the muscle of our heart as well. And this is just natural ways that hormones work in our body. And progesterone and testosterone do very similar things. So it goes without saying, really, it's quite obvious when you know the understand basic science, is when you don't have those hormones, you have accelerated atherosclerosis. you have increased atheroma, you have a hardening, if you like, of the arteries, you have raised blood pressure. And so all of these will increase cardiovascular risk. And so we've known for many years that when people become menopausal, their risk of a heart attack, stroke, raised blood pressure increases quite exponentially. Because obviously, when we're younger and we're producing hormones, our risk of a heart attack is a lot lower than men. But then we catch up men after menopause. So we've known that for a long time, but the confusion has been from studies, including the Women's Health Initiative study, basically showing that there was this increased risk of heart attacks in women who took HRT, especially over the ages of 60. But of course, when you look at that study, it was using conjugated equine estrogens and it was using medroxyprogesterone acetate, which is a synthetic progestogen, which we know has an effect on the cardiovascular system in a negative way. And we know it also has other risks as well. So you can't compare that to the way our natural hormones work.
So, in fact, HRT seems the logical approach. So, can you say anything about the proportion of women who are actually receiving HRT and therefore how many are not receiving HRT? Because it seems as if everybody should be.
Yeah, so isn't it interesting actually? The NICE guidance, which as you know, been updated, are very clear on the top level that the majority of women would benefit from hormones. So it's first line treatment for menopausal and perimenopausal symptoms. Whereas let's have a look. In the UK, the average prescribing for menopausal women is about 14% of women are prescribed hormones. In the US, it's about 4% of women. We can't know the figures for real because a lot of people have compounding, which isn't in those figures. But before the WHI study, the Women's Health Initiative study came out, so that came out in 2002, many years ago now, HRT prescribing in the UK was about 30% of women. So we're still under half of what we were all those years ago. And in the US, it was about 40% of menopausal women. So I'm not a statistician. I do know quite a lot about mathematics, but 14% is not the majority. And you see, I don't mind whether women take hormones or not. A lot of my work's been misinterpreted that I think everybody's like should be taking hormones. But what's really sad out there is women do want to take hormones and they're not being prescribed them. About 1 in 6 women at least are prescribed antidepressants. Now we know antidepressants have side effects, they're addictive, they're associated with an increased incidence of osteoporosis, and they've recently been shown to have an increased incidence of dementia in people who take them long term. I've already said if you're menopausal, you've got an increased incidence of osteoporosis and dementia. Now, some women need both. They need antidepressants, or they might only need antidepressants. But I'm not aware of psychiatrists and doctors and clinicians sitting women down and telling them about the risks. And of course, there's also a risk that they won't be able to have an orgasm and their sexual desire will reduce. But somehow, when you talk about HRT, the first word that comes up is tell me about the risks. So, yes, there are risks with the synthetic hormones in the same way there are risks with contraceptives. But again, my daughters have been offered contraception numerous times by numerous doctors, and no one's talked to them about the possible risks. So it seems just a bit like weird that there's just this big focus on the bad guys, which are our natural hormones.
Can we come back to the mental health impact? I understand that many women are treated with antidepressants and even antipsychotic agents. Would you like to say more about that?
Yeah, I'd love to say more because it's the one thing that keeps me going with my work because it's so awful actually. And I'm speaking in a general way, and I know I see a skewed population of women and hear from a skewed population of women. But I've been funding a PhD student in suicide prevention for 3 years, and we found that 1 in 6 women who come to our clinic have suicidal thoughts. And I've actually lost count the number of women I've seen in my clinic who have been under psychiatrists for many years and they've had antidepressants. Most women have been offered or given antidepressants inappropriately, but they've been given antipsychotics, they've been given lithium, they've been given sometimes ketamine infusions, and also they've been given a lot of electroconvulsive therapy. I didn't realize how commonly it had been used for some women, and their diagnosis has been treatment-resistant depression. But when you take a really clear history, and obviously a lot in medicine is from the history, they'll tell you that they've had really bad PMDD for many years. They'll tell you that they've had postnatal depression. They'll tell you they felt really great mentally when they were pregnant. And they'll tell you that they fell off a cliff at the age of 48 or whatever. So you don't have to be a hormone specialist to understand that some of it's related to hormones. But the other thing actually that really concerns me is that the antipsychotic medications will give a chemical menopause to women because it will increase prolactin, which will then, as you know, will suppress FSH. If you've got a suppressed FSH, it will suppress your estradiol, progesterone, testosterone. So we all know that many antipsychotics can induce metabolic syndrome, increase incidence of type 2 diabetes, can increase hypertension, can make people amenorrheic and have this sort of retarded way of thinking. But no one's checking their hormone levels or even thinking about them. So if women have, another condition unrelated to their hormones that needs an antipsychotic, why aren't the psychiatrists screening? Because they screen for thyroid function tests if someone's on lithium, and they do cholesterol levels on people on antipsychotics. There are some questionnaires that they sometimes give patients and ask about their periods, but they don't prescribe hormones. So I think this again is a real problem, and I really worry about it because I see, the harms of some of these medications, and I also see like the transformational effects that can occur in women who are then given hormones. And it's lovely to make people better, but often people have missed out on their life, sometimes for years, sometimes for decades.
Mm, mm. Of course, suppression of sexual responsiveness, sometimes permanently with some of these drugs, is a terrible price to pay. Can you comment further?
Yeah, isn't it interesting? Because I sometimes say to my daughters, actually, I feel quite embarrassed being a doctor. Some of the terminology that we use and some of the criteria we use to prescribe medication. So, if I give you an example, and I'm just picking up on your point about women, does it matter if they can have an orgasm or not? And, I talk about anything to my patients, and for some women, it's irrelevant. They don't want an orgasm, but other people, it's very important. But if you think about testosterone prescribing for women, I've already said testosterone is an important hormone. It has effects on the cardiovascular system, but all over the body. Now, nice guidance say that we can consider testosterone if women have reduced sexual desire despite taking hormones, which is sort of okay because that's what the evidence shows. But some menopause societies and some individuals go further than that, and they say women have to have HSDD, which is hypoactive sexual desire disorder. Now, if you look very closely at the criteria for this, one of the criteria is that women have to have severe psychological distress with their reduced libido for at least 6 months after having a full biopsychosocial assessment. Now, as a doctor, I don't really want any of my patients to have severe psychological distress with anything. I don't understand why I have to wait for 6 months, and I don't understand why it's always going to affect you psychologically and socially and biologically. But it also says if there's no other factors, for example, alcohol or drugs involved. Now, I think of some of the people that I see who are from really deprived areas. They might have quite an abusive partner that's getting more abusive because they're not having a sexual relationship because he's frustrated. He's drinking more, she's drinking more to try and whatever. So therefore, she wouldn't even fulfill that criteria. And I see it. This isn't just made up because I see all these women, and I saw a lady in my clinic the other day, and she said, "Well, my doctor said I've had a divorce, so I don't need a libido, so he's going to stop my testosterone." And this is where I'm embarrassed as a doctor because how can we control someone's sexual health with a natural hormone? Like I could understand if I was giving a drug like ketamine, for example, we would want to reduce giving that. And I don't prescribe the gabapentinoids, which some people do for hot flushes. But this is a natural hormone. And it's all gets really obsessed with the data, and we only reserve it for these women. And I was trying to look the other night, is there a male equivalent of HSDD? And if there are they so strict? Because I'm not a man, but if I was a man and I wanted Viagra, surely I just need my credit card to get Viagra. I don't need to prove that I've got HSDD. And obviously, Viagra works differently to testosterone because we know from our data, and we've known data for decades, that testosterone can improve mood, energy, concentration, stamina. Yes, it can help orgasms and libido, but it's more than that. So it feels just really weird, and I can't quite understand why it's so controlling by doctors. What have they got to gain from it? Because as a doctor, I'll often give a therapeutic trial and say, well, try this. If it doesn't work, we'll try something else. But somehow it's become very, very controlling that you can only have it if.
Hmm. You've given us a great deal of food for thought. Now, in an ideal world, what needs to be done? How can menopausal women be served better?
So I think we should actually try and get rid of the word menopause because it's very confusing because it just literally means stopping periods. But if you look up the definition, it's for a year. So it's even more confusing. But like I said earlier, when I'm thinking about hormone replacement treatment, I'm very precise about progesterone, estradiol, testosterone. And I think we should be very precise about talking about a progesterone deficiency, an estradiol deficiency, or a testosterone deficiency. Because, for example, if I see someone in my clinic who's got PMDD, premenstrual dysphoric disorder, she might just need some progesterone for 3 days of her cycle and it will transform her life. So she is progesterone deficient for 3 days a month. I might see somebody else who's having no periods at all and she's very low in her estradiol and progesterone. So therefore, it explains. I might see other women in their 30s who have very regular periods. Their main symptoms are brain fog, reduced concentration, low energy, muscle joint pains, and their testosterone levels very low. So they might be testosterone deficient. And so then we can just say it what it is, really. And I think that's really important. So I think we need to change the language a bit. I did go to the Royal College of GPs about 8 years ago. So could we just change menopause to FDH, so female, FHD, so female hormone deficiency? And they were like, oh, don't be ridiculous. It's not even a conversation we'll entertain. And I think, well, let's just be really clear because I think as a patient myself, I want to have a label that's going to help get a treatment. And so that's something. But I think we should also be thinking about hormones differently. We should be thinking about what they are. They're biologically active chemical messengers that are really important for our cells and bodies to function. I'm very interested in the immune regulating effects of hormones. And so we need to remember that when we're thinking about future disease. So it's not just a hormone deficiency. We could also add the caveat with health risks because it does. It's fact. I'm sorry if it's upsetting people, but this is fact. And we've known it. None of what I've told you today is something that I've made up. We've known it for decades. It's just been suppressed. And the other thing is thinking individually for that patient. I'm not here really to help big institutions to change. I'm not here to work with pharmaceutical companies. I'm here to help the patient in front of me. And the best type of hormone is the body identical natural hormone for those women. And we need to be thinking differently because otherwise, when we say hormones, people think about every single hormone and they're not. The synthetic chemical hormones are different. So we just need to be thinking differently, women and healthcare professionals.
That's very helpful. And last question, how can healthcare practitioners and prescribers upskill themselves in menopause matters?
I think we need to be really clear about how we train healthcare practitioners. And the most I learned actually was 10 years ago, I sat in people's clinics. So I was very fortunate. I went and sat in Professor John Studd's clinic, who is now sadly died. And you might know he set up the first NHS menopause clinic in 1974, which was closed quite soon after by the British Medical Association because they said there was no need for such a thing. So he had a difficult time actually. He was misunderstood, and lots of people tried to really take him down. But he was a good clinician, and he thought outside the box. He taught me about just treating like with like and the difference between the natural and synthetic hormones, which is really obvious when you know it, but if you're not taught it, you don't know it. And I sat in other people's clinics, and then I became very inquisitive and just asked and read and asked and read. But people I understand obviously don't have time to do that. So, I mean, when we set up our confidence in the menopause course, it was many years ago, it was before COVID, but I was really tired and a bit fed up of going to conferences where I'd put my children into childcare, go on a long journey, spend a lot of money, sit and fall asleep in lectures, looking at slides that have been done 20 years ago and thinking, this isn't really helping me when I've got a patient in front of me. I need to know what to prescribe, what to sort, how do I talk to her? How do I really understand what's going on? So that's when I decided that we were going to video some mock consultations with actors and then signpost to the literature and really allow people to get that information, which I've done, and also really worked hard to empower patients, if you like, so that women can come a lot more prepared to their consultations. And I know some people don't like the patients being central to the decision-making process and consultations, but I do. And that's the way I've been taught as a doctor. So I think educating our patients is as important as educating healthcare professionals. But, there's quite a lot of conflicts and bias in medicine. So we have to be careful because there's lots of people crowding this space. There's lots of people who are training in menopause, but they're funded by different organizations, including companies that make non-hormonal drugs. So I think we need to be also clear that when we're teaching, medicine is a science and an art. So we need to know the literature, of course we do, but we also need to be taught by people who see a lot of patients. And a lot of people who run courses often either don't see any or many patients because they're sort of maybe a general gynecologist with an interest in menopause, but they might just see 2 or 3 women a week. And as a gynecologist, you're not going to see someone with mental health conditions because they won't go to a gynecologist. They'll go to a psychiatrist or a GP. So, of course, I'm biased because I'm a general practitioner, but I think it's really important that people need to look at the body as a whole and not just think about it as a gynecological condition. And, I've done a lot of training for pharmacists and for nurses as well. And, that's really, really important. Look how it's changed with diabetes care. I used to run a diabetes clinic when I was a senior house officer at Manchester Royal Infirmary. And now, I don't even know the drugs because the nurses do it. And the same with contraception, and I've already said contraceptives have more risks than HRT, yet you can get the morning after pill over the counter, which has far more risks. So we need to empower other healthcare professionals as well. It's like, otherwise it's a bit of a Cinderella specialty and it's just a sort of bit of an old boys network with just the gynecologists. And don't get me wrong, gynecologists are great and they can know as well, but we need to involve every healthcare professional when it comes to training.
Dr. Louise Newson, thank you very much for talking to us about this important topic. That really has been terrifically interesting and thought-provoking. For more information about Dr. Newson's work, please visit the website using the links in the description. And be sure to sign up for more videos, journals, and podcasts. For updates straight to your inbox, please follow the links below. And thanks for watching.